My name is Scott Luna, and I'm a dentist and a father, and I have the pleasure today of interviewing Dr. Justin Workup, the founder of the Breathe Airway Method. In today's interview, we're going to learn about how a child's airway can impact their behavior in school. A child's airway can impact their health as an adult. It could impact their overall well-being. There's a connection between an infant's ability to breathe, a child's bony structure of the face, and ultimately how well and how happy they are in life. It's an area of holistic practice and dentistry that is not very well known, and Dr. Justin Workup is one of the pioneers. All right, so Dr. Workup, thank you again for joining me. And before we dive in too much, could you please talk about why you founded Breathe?
Yeah, as a resident, I had an amazing attending. So I'm a pediatric dentist by specialty, but we would spend about 6 to 8 weeks with the pediatricians and had a pediatrician who pulled me aside and said, Dr. Workup, 80% you'll learn in your residency, but 20% you'll learn being a dad. And as I watched my own children grow, and I was doing, all things in the practice, I used to do all the orthodontics in the practice, all the pediatric dentistry, all the laser lip and tongue ties. And I started noticing some issues with my own kids. And I have one of my kids who really struggled with nighttime bedwetting. And we tried everything. We tried medicines. We tried alarms. We tried sleeping next to him on the ground, trying to wake them up in the middle of the night because they felt a lot of shame with it. And my wife and I felt really exacerbated. We wanted to find a solution to it. That in conjunction with, I was finishing orthodontic cases and I would look at their teeth and I would say, your teeth look great, but something's wrong. And then I ended up getting a CBCT x-ray and I started having just curiosity and started looking around and taking scans and evaluating and not really knowing exactly what I was looking at. Fast forward, pandemic, a lot of different things happened, ended up meeting a couple wonderful mentors. And that all came together and allowed me to realize that there was a giant hole missing. And as I started having parents come in and having similar questions that I had as a parent and saying, is there something we can do? And for a long time, I would say what every other pediatric dentist said. I would say, oh, they'll grow out of it, and realize that kids weren't growing out of it. And we were actually lying to parents and just trying to, placate them to get to the next patient. And so I started realizing that there was great data out there, how the growth and development of the growing child in the formative years, and as we change the nasomaxillary complex through guidance growth therapy, we actually really change the trajectory of their life.
So I've got a daughter who's 7, and she struggled with bedwetting. She struggled with behavior in school to the point where we were told maybe she needed medication. She struggled also with behavior at home. It seemed like she was upset a lot. It seemed like she was on edge. And of course, we couldn't have any sleepovers because she was embarrassed about the bedwetting. And so we were waiting for her to grow out of it. We're hoping for her to grow out of it. So what you're saying here is when a young child has a problem with their airway, that could result in these behavior issues and this bedwetting. And that problem isn't necessarily something that most pediatric dentists are trained on or most orthodontists are trained on. Did I say that correctly?
100%. You're exactly correct. And what you described is what I think a good majority of parents are wondering and questioning those same things with their own kids. If I look at my own residency, we didn't get any training on it. And if I look at, I practice in the Dallas-Fort Worth area, a lot of the orthodontic residents will come out and say what we call phase 1, that formative orthodontic treatment through the traditionally the 8 to kind of 9, 10, 11 years of age. They get very minimal training on that. And so we looked and saw that there was a really big gaping hole. And then fast forward to as I began to practice and I would go to courses and talk with orthodontists and they would say, how do you do this on a 3-year-old? On a 4-year-old, where the American Academy of Orthodontics says they don't want to see a child till 7 years of age. But by 9, almost 90% of the facial development is complete. And so those early years are absolutely important because if we can make those changes during those major growth, and we're talking 40 to 50% of those growth of that nasomaxillary complex is that 3 to 7, 8, 9. And if we miss that, we miss a giant opportunity to make those changes. Into the changes that you said of behavior, school, focus, sleep, health, all of that is associated with health. If we look at what happens at night, we'll go back to being a dentist yourself, go back to the physiology days of the Krebs cycle, right? We need oxygen to create energy.
Mm-hmm.
And if we are not breathing properly, our oxygen capacity to be able to transform that into energy, into focus, into all these other things is going to be decreased. And we're going to see it come out in one way or another. Sometimes it's the inability for a child who's so tired to have their mind wake their body up that says, my bladder is full, I need to go to the bathroom. Other children who are going to school and trying every which way they can to focus and to be a quote unquote good, child in school, they're trying, but their body's saying, I'm so tired. I'm constantly in a fight or flight situation. Their body has a cortisol level that's skyrocketed, and they can't overcome those deficiencies that they're getting by improper sleep.
So it sounds like sometimes children are told they have things like ADHD when really it's an oxygen problem when they sleep. However, I think what I'm hearing you say is that the best time to treat a child that may have this issue developing is when they're really young, age 3. But a lot of times we don't see these symptoms as parents, and we don't actually finally seek help until they're older, age 7, age 8. So as a parent, what should I be doing? Should I be proactively bringing my child to be screened for this? How does that work?
Yeah, 100%. I think one of the important things is I start seeing kids as young as under 24 hours old. A large part of my practice is early lip and tongue tie development for breastfeeding children. The single best thing that a parent could do for a developing child for the development of the nasomaxillary complex is breastfeeding.
Mm-hmm.
And so when I have a patient come in, I start that process on day one. We talk about training on how to, as a child is in mom's arms, of how we can begin the training to facilitate nasal breathing. And that's rewiring some of the things that have been lost. Because if you look at, we call them, again, epigenetic changes, how our environment has changed our overall genetic code, in that we are genetically now selecting for smaller mouths. Some people will say 5 to 10%. Sometimes I look at kids and say, man, that's almost 20% smaller than what our ancestors as young as 300 years ago used to be. And what happened? Well, we started to process our food. We stopped developing our facial musculature. So we can do dietary changes and how we avoid things like processed baby food, right? Because we're not allowing them to begin to develop the musculature. We can do things like myofunctional therapy. We can do other adjuncts depending on the age. And so a lot of times people say, when's the best time to start? Well, yesterday. When's the second best time to start? Well, today. And that can be at any time. And there are, whether it be 3, 4, 5, 6 to 15 to adulthood, there are some amazing non-surgical approaches that are rapidly growing every single day.
Well, sleep apnea for adults is such a massive problem. And it's resulting in adults, of course, having, a shorter lifespan and all kinds of other issues. But what I'm hearing you say is that if we look at the cause of this, over time, we as humans have been eating differently, and our jaws have been becoming smaller. And that has resulted in an airway problem, in a problem to get oxygen. And you're saying that as early as a day old, when we are breastfeeding as babies, we are able to start learning as a child how to breathe through our nose. And the pressure we're putting on our jaw over time hopefully allows it to be a correct size. But what I think I hear you saying is, you said maybe 20% or more are already going to have a jaw size that puts them at risk of this problem. Did I hear that correctly?
100%.
Oh, so then part of the solution here is being able to treat a small child in a way that their jaws aren't shrunk, that their jaws are the correct size. And as a result, they're able to breathe better at night and during the day. They're able to nasal breathe. And if we move forward, that means they're getting the oxygen they need. So they don't have all that cortisol. So they're not desperate for sleep. And they're able to now not be a bedwetter. They're able to have more focus during the day at school. They're able to behave as we would hope they would want to. Is that the domino effect of this?
That's exactly correct.
Okay, so if I am let's say my wife has just had our next child. What's the protocol? What should I, so when should I bring my baby in? When are they old enough to understand, is there an airway issue that might need treatment? How does that work?
You know, I think starting from the very start is as we're watching them breathe. That's one of the things about our modern world. We have cameras and things, and we can watch the children breathe. So we're listening, we're watching, we're looking for the ability to have lip competence or to be able to keep our lips closed and breathe through our nose during the day. Do we hear audible snoring? And so do we have feeding issues? And so all of those things are signs from birth that we can see. And I think one of the amazing things is the modern mother of today, I think, is becoming much more aware of that. But I think what is happening is they're becoming aware and saying, now I don't know what to do. And so I think as soon as we see something that, and I liken to, I tell a lot of mothers that to begin to believe that voice on their shoulder, that mother's intuition that tells them something's just not right. And as soon as that happens, we need to go start to find somebody who has solutions. And that's what we're developing. And I think that's what we've really begun to develop. And I feel like we're growing in our development every day. And so that can be as young as 1 year of age. Someone may not find it until 3, till 5. All of those times have a little bit different treatment path and a little bit different way we might go about it. But I think as soon as we have that little voice in our head that says, is this right? And is this exactly what I need to look? Or do I need to look for something to make a change?
So it sounds like the earlier our child gets seen, the better and easier it might be to treat them. But if these things don't pop up until they're 3 or until they're 5 or until they're 7, there are still ways to address this and correct this.
100%.
Right? Okay. So, before we dive into, what is this revolutionary kind of therapy that you've developed for dentistry, Breathe, before we dive into that, I want to kind of sum up maybe the symptoms or the signs. If I'm a mother and I'm looking at my child and I'm really attuned, noticing the tiniest little details of what's happening, what are some things I might see that would tell me, okay, we might have something going on here? I think I heard you say snoring could be one of them. Problems feeding could be one. Bedwetting and behavior problems at school or behavior problems at home. Are there other things, other signs that I might look for or things I might listen for?
Yeah. Things like grinding at night, audible sounds, waking up tired, waking up with dark circles under our eyes.
Sometimes I see babies almost gasp for air. Is that also a symptom that there may be an issue?
100%. On the one-off, of course, we're all going to have moments like that, but the consistent of those signs showing up over and over, those are absolutely signs.
So if snoring happens consistently, maybe not all the time, but my baby snores, or if my baby sometimes wakes up to breathe, or my baby's very restless trying to sleep, or my baby's got a hard time during feeding. They're unable to breathe. Maybe they have to take breaks to breathe through their mouth because they're unable to breathe through their nose. Or my child has consistent issues at school or consistent bedwetting. All of those sound like are strong red flags that say we need to look at this. Is that correct?
You're absolutely correct.
Okay. So let's dive into what Breathe is. From someone that maybe isn't a dentist and has never heard of these types of concepts before, how might you describe Breathe? What is that?
Yeah, Breathe is a method that we use to look at the overall body. I always say for the longest time, I've been a pediatric dentist for 12 years now. And for about 8 years, I treated teeth. And then I realized I see the kids more frequently than the pediatrician does. And I'm missing this giant opportunity to treat the body. And so the more we start getting into kind of more of a holistic approach, a whole body approach. And so again, you mentioned at birth, right? We're going to scan and evaluate for a lip and tongue tie. For me, my personal belief is the lip and tongue tie doesn't cause the breathing or the feeding issues. It's actually the smaller mouth. Mother's breast shape, size, well, that's all stays the same for millions of years. But it's trying to enter into a mouth that's 10, 15, maybe even 20% smaller than what it used to be. Again, teaching parents that, I always say I give my dentist answer, my dad answer. As a dentist, no passy is a good passy. My dad answer is I had 4 kids. Every blue moon we needed a pacifier.
Yeah.
But things like a Webinub, that's the pacifiers that have an animal attached to it, those little kind of, stuffed animals. That's like us as adults carrying a 10-pound weight for hours on end in our mouth. That's going to create some changes and some problems, in particular in a child whose bone is adaptable and malleable. And so we need to educate them to realize the things that are going to consistently get them off track and things that can help them stay closer in line to causing further detriment. Then there's things as they grow and develop. We're going to look at, are there blockages from the tonsils and adenoids? That's the great thing that we have CBCT machines now. And that's a 3-dimensional x-ray where we can actually see the size, measure the size of the tonsils and adenoids. And that way, if you look at most ENTs, they will say, well, have you had strep a certain number of time and a certain number, and then, oh, maybe you might need your tonsils and adenoids out. But again, that's treating just the tonsils and adenoids and one specific symptom. But when we start to broaden that, and then we can physically look at them without a scope or having to put a child to sleep for it, now we have the ability to work collaboratively with an ENT to say, is that something we need to do? Do we have a complete blockage? Mm-hmm. Then we're going to look at things like orthodontic expansion. That's kind of where really I kind of physically will step in a lot of times, where we will do expanders and we will then develop the jaw. The younger we get, we don't get just changes in the jaw, but we get changes in the nose. And I think that's the important thing. The younger a patient is, the further up that bony change grows and develops. So people nowadays as adults will use breathe tape, or there is a new, magnet that they'll put on their nose that will help open up their nasal passageway. Well, imagine if we can actually expand the nasal passageway. And there's a law in physics called Poiseuille's law. I'm probably, pronouncing that incorrect, but it helps us understand airflow through a tube or cylinder. We can think of our nose as a cylinder. And when we change that diameter or that radius, even just a small amount, we get a 4th power change to the ability to get airflow through the nose. Mm-hmm. And so the younger a patient is, we can create those changes. But then some of the other things that are absolutely important is myofunctional therapy. So myofunctional therapy is kind of like speech therapy, but I always say it's kind of like more physical therapy for the tongue. All of us as humans, because our mouth is smaller, we are using our tongue inappropriately. We're breathing inappropriately. We're swallowing inappropriately. And we need that one-on-one training. And mothers need that help of somebody. We always say, as a parent, I love when somebody else is that support for me. And that's what a really good myofunctional therapist is. And I can't do my job correctly without one. Mm-hmm. Then we're scanning for, again, if they didn't have it as a young child, and even if they did have it as a newborn, do they need a lip and tongue tie? There's a very specific surgical approach once a child is older that gets the very best result, even better than a newborn. And we're bringing all these things together. And then as a child gets older, there are some more, maybe we might consider maybe more invasive, but they're still non-surgical. A treatment with an appliance called a MARPI. Mm. And that's where we'll put implants on the roof. We'll attach an expander with implants to the roof of the mouth. And those changes are absolutely incredible. And we can then make those changes now even into adulthood.
Okay, so I'm going to attempt to kind of restate a lot of what you've said. It sounds like the breathe strategy, or the breathe technique, is a basket full of things that improve the child's ability to bring in oxygen, have a proper airway. It sounds like it starts with looking at the child to see if there's a tongue tie problem as a newborn. And that might need to be addressed if the child has that. And that sounds like it's a very simple procedure to do for a baby. Then you mentioned using an x-ray called a CBCT, which is going to scan and look at the size of the tonsils and airway. And this is wonderful for children because decades ago, they'd have to be put to sleep to look at these things. Yeah. But now we can put them in this very simple x-ray. And there you can measure things to see if we're kind of out of health or not, if there's an airway problem.
Correct.
From there, you talked about the size of the child's jaw. And potentially, especially at a young age, you have the ability through Breathe to expand the jaw to a proper size. And you spoke about how that will help with the breathing. It'll also help expand the nasal passageway. And then from there, you spoke about something called myofunctional therapy, which you said is like physical therapy for the tongue that can help mom train the child on how to use their tongue the way it's supposed to be used. And if that child has other issues later on in life, there's also other things you could do. It sounds like with the placement of implants, where you can get a beautiful result expanding the jaw. Did I describe that correctly?
You're correct.
Okay, and I've seen these studies where there were these two twins and they were kind of separated at birth, and one was in this environment where their jaws were small like the rest of us, and one was in another environment where their jaws were the proper size they should be. And the one with the smaller normal, we call it normal, but the smaller jaw had problems with breathing, problems with sleep apnea, and they actually just didn't look at as an attractive adult. And the one with the larger jaws did. And so is it safe to assume that if we just look at the vanity side of things, but when a human grows up with the proper expansion of their jaw and the proper kind of passageway of their nose, that kind of strong physical feature is something most of us would also view as very attractive. Is that the case?
You're correct. There's been study after study that has shown that a strong jawline, in particular, let's say for a male, it shows, if we look at our kind of prehistoric mate selection, it showed the ability maybe to protect, right? To protect your offspring, to protect your family. And so as those things change, how it works in our modern world now is we naturally go into that questioning of maybe this person isn't as qualified for this job. Maybe they don't have, the same attention span, whatever it may be. And because we're fighting those millions of years of our genetic code, trying to tell us what is safe and what is going to allow us to pass on to, further generations. Right.
Yeah.
And so you're absolutely correct. Whether it be from dating for an individual, whether it be job selection, all those things from the quote unquote vanity side of it are part of it. Yeah.
And what we're seeing today is because we all have this kind of sunken in chin and the smaller jaw, it's actually very common, isn't it, in children getting braces, where now the orthodontists are having to pull out normal teeth, premolars, just to make space because their jaws are so small they can't even fit a normal amount of teeth anymore. Is that correct?
Absolutely. We really, if you look at the data, about 20% of orthodontic cases, even today, are what we consider extraction cases. And that's where we take out usually 4 permanent teeth that aren't the wisdom teeth. The problem, what happens with that is when we take out teeth, we pull all the teeth in and we make less room for the tongue. So let's say we have a person who they're already showing signs of snoring, maybe what we call UARS, upper airway restrictive syndrome, maybe pre-sleep apnea, and then we take out teeth and make it smaller. We're just writing them a one-way ticket to obstructive sleep apnea as adult. And really the obstructive sleep apnea, long-term, not treated with the CPAP, that's stroke or heart attack. Yeah. And so you're exactly right. But even to that, let's go back even to just the aesthetic and vanity side. When we look at a smile, I had a mentor used to say, everybody wants to be Julia Roberts and Angelina Jolie because their smile is incredibly broad and it's very youthful. No matter if they have that smile now and they're 20 or now they're maybe in their 50s, they look incredibly youthful. And even if we look at some of the, cartoons that are made, that's how they make a smile in modern cartoons. But when we take out teeth, we create what are called dark corridors. And it creates this darkening and it ages the face. And so you again take two people, let's take the two twin brothers who have the broad arch form. We're going to have overall health better, low cortisol, better breathing, probably overall health trajectory is going to be better ability to maybe maintain a healthy weight. Then we take the other and we're going to see much different trajectory in their health and their just probably overall life satisfaction.
So for now, a couple decades, we've actually been hurting our children in a way. We've been failing to see the signs of a breathing problem. We've been treating them with medication because we think they have ADHD. When they get braces, we're taking out perfectly natural teeth and shrinking their face even more. It's making them look less youthful, less attractive. It's causing more risk for sleep apnea, which results in eventually more weight gain, more chance for stroke, more chance for heart attack. And that lifelong domino effect was started as a baby. And I think what I hear you say is breathe can start as that baby and prevent that entire domino effect. Is that a right way of looking at it?
Yeah. What I tell patients a lot when they come in is this might be ideal.
Mhm.
As an overall, north south of where we used to be, we are all headed off on an incorrect trajectory.
Mhm.
Breathe may not be able to get them to where we used to be 300 years ago,
Yeah.
but we're going to stop that trajectory that's taking us away from health, and we're going to be able to correct. And it's going to be in a safe and a simple and a very holistic manner. And we're going to bring in as much as we can to try to prevent, then try to then treat the problem. And that's the difference between, as dentists, we are taught to just treat the problem. We see a cavity, we fix a cavity.
Yeah.
We want to learn how to prevent cavities from developing. We're improving in the dental field with that.
Mhm.
But the more in which we start from a younger age, we're going to be able to prevent those problems. We all know once the weight gain happens, it's hard to make those lifestyle changes to get it off.
Mhm.
Otherwise, all of us would be skinny and healthy.
Yeah.
And so the younger we start, the easier it's going to be, because then those changes are going to be easier for us to maintain.
Okay, so I'd like to ask you just a series of short questions, short answers, just to kind of bring this all together, because most people obviously haven't been trained. They don't have the doctorate you have. They don't have all this experience. And so some of this language can seem a little confusing. But I want to try to see if we can make it simple for everyone. So first question. My wife has a baby, few days old, and we want to make sure that the baby doesn't have something called a tongue tie, and that during feeding we understand what that's supposed to look like we get help understanding what to look for. Do I bring them to your office? Do I start this kind of breathe treatment? How does that work?
I think coming to my office, that would be great to allow me to do an assessment,
Mhm.
but also to ask enough questions to find out how confident are they in meeting their breastfeeding goals,
Mhm.
because then I can help pair them with a really good lactation consultant.
Mhm.
And that ability to, again, learn to develop the musculature in a way to help continual guidance in growth of the face is absolutely important. And so, yes, bringing them to me, but then it will probably be being the quarterback. And that's what I tell parents a lot of times. A lot of times, I may not be the person doing the treatment, but I may just be the quarterback
Mhm.
to help facilitate the referral to the right person to help with the specific symptom or treatment that they need.
So then, as at the age of baby, we're thinking about, is there a tongue tie issue or not, and is feeding going well or not? Is that correct?
Correct.
Okay. And what kind of doctor would tell me if there's a tongue tie? What is that like? Or if you could, what is a tongue tie?
Yeah, that's a great question. So tongue tie is it's a little piece of tissue that's underneath the tongue.
Mhm.
And it's one, I always tell people, finding a tongue tie is like finding a big toe. It's something that's supposed to be there.
Mhm.
But what we're finding is in our mouth, and now again, because if you look back, again, we're talking 300-400 years ago, we didn't have bottles, we didn't have pumps, we didn't have all these other ways to ensure that a child got the nutrients that they needed to be able to live.
Hmm.
So if they had a severe tongue tie and they couldn't breastfeed, they didn't make it. That was our natural selection, unfortunately.
Hmm.
So it's wonderful now that we have the other options. But when we look at it, we're looking to see the severity of the immobility of the tongue, the size and space for it to fit. Do we have the ability to elevate, extend, and utilize the tongue in a proper fashion? The difficulty with it is I did 4 years of dental school, 2 years of pediatric residency. It was talked about a single time, not by an attending, in some remote, tiny little town in Ohio, where we went our 4th year to go get a little bit of training in some remote clinics by a doctor who knew it. Now I understand maybe very minimal about it. And so it wasn't talked about. So we have to actually go outside to gain that understanding of lip and tongue. There's a lot of great individuals now who've done a lot of research that have helped really bring that to light.
So it sounds like the connection below the tongue is a normal thing to see, but the connection sometimes is so much that it gets in the way of feeding, which can ultimately hurt the baby because they can't get as much oxygen as they need. Did I say that correctly?
That's absolutely correct.
Okay. And the procedure to fix as a small, simple procedure that it just happens in your office, or is that a hospital procedure? What is that like?
Yeah, it happens in office. We first come in. I really find it best if a individual has met with a lactation consultant. It's a very team approach on the infant stage. Sometimes that's bringing on somebody who does what we call body work. That might be a chiropractor or an osteomanipulative medicine. But then coming in and assessing, finding out what the goals are that the parent has, what are the potential risk factors. And then it's a simple procedure with what we call a CO2 laser is the latest technology. Being able to perform the release properly, but then the absolute most important is the aftercare. So the thing that inhibits success of a proper release at an infant at a young age is actually ensuring that the aftercare is done properly to get the very best result long term.
Okay, so it sounds like at the infant stage, I need to make sure that we don't have a tongue tie issue and that the feeding is being done properly. And so I'm going to have a team of specialists, including a lactation consultant and yourself, to help me understand how are we doing? Do we need to do anything differently? And it's so important at that age. What age are we at when we start looking at the tonsil and airway size and the arch size? Is that also at that young age, or is that now in a few years? How does that look?
Yeah, I'd say with like the tonsils and adenoid aspect, we're going to probably be a little bit bigger. We need a child to be able to sit still for a CBCT machine. It's a little variable for every child, say maybe about 3 for that. But we're going to start even in the tongue tie assessment of, are we noticing mouth breathing? Because there's some specific types of training that we can do. Again, we're imagining mother having baby in their arms, right? And they're noticing mouth breathing. We're going to train them on how to close the mouth, and then actually push gently underneath the tongue to facilitate the tongue to elevate into the roof of the mouth. And then we're going to let little baby, little Johnny, little Sally breathe in and out through the nose for about a minute. And then we're going to delatch the tongue by pulling down on the chin and getting that click to ensure that we've had a proper elevation of the tongue. That tongue sitting on the roof of the mouth, that's nature's palatal expander.
Yeah.
God created us to have our tongue on the roof of the mouth, to have that be what helps create the proper size. And so let's say we fast forward, we're past the breastfeeding stage. We're in kind of the toddler infancy. Once we start getting into that toddler stage, we can look for some myofunctional therapy. And there's an appliance or device. The kind of founder original device is what's called a MyoMunchie. We also have the breathe appliance that we recommend for patients. And it looks like a football mouth guard, actually.
Okay.
And what we do is we have the kids wear it, and they do exercises. They do chomping, chewing exercises. And then we also like to have them sleep with it. So what does it do? Okay, again, let's go back 300 years ago. We're in the middle of the prairie. We didn't have a Kroger or, Tom Thumb down the road, right? And so we needed to have food that was going to last. So it probably didn't taste very good. It's probably really hard and really difficult to chew. We didn't have knives and utensils. And so we were biting and tearing and chewing, and our masticatory forces were really strong. And so it mimics what our diet used to do for us. So again, we talked earlier, right? Developing that stronger jaw. That's that musculature here. We call it our masseter muscle. It used to be, some people say maybe 40% broader than it used to be now as our face shape has changed. And so as we start to develop that, we're going to increase those musculature, which is going to help broaden it. But it also does some other things. To keep it in, you got to keep your lips closed. So again, you have to then, if your lips are closed, you have to breathe in and out through the nose.
Yeah.
It trains how to posture the tongue on the roof of the mouth. So again, the tongue is nature's palatal expander. Then it's going to help develop musculature. It pulls the lips away from the teeth, so it helps prognathic growth. So it's helping do all those things that our diet used to naturally do. Is it going to get us where I want us to be on where we used to be 300 years ago? No. But it's going to really stop and only do a positive and improve. What we find, though, a lot of times is for a mother working with a 2-year-old, and if I tried to get my 2-year-old to put in a MyoMunchie and do a bunch of exercises, she was going to struggle.
Yeah.
And my wife would have looked at me and just said, Justin, I love you, but there's no way. And so that's where our office and our team is trained to be able to help support parents, how to help them become successful, how to have another voice so that mother and father don't have to be the only voice that the child hears to help develop the skill set to be able to utilize it. Once we've done that, then we're looking at that 3-4 years of age is when we really can start to do the deep dive, where we can look at the entire structure. That's start to finish. We get pieces those first few years.
Mhm.
And then once we get in a child, it shows the signs of being comfortable. We want to start as early as a child is comfortable. That's very variable.
Yeah.
Every child's gonna be a little bit different. That might be, we've started as young as 3. I'd say the average 4.5 is when I feel very comfortable with nearly probably 95% of kids that I could work them through treatment in a manner that they felt cared about and loved. And so those are kind of the different stages that I'm looking for specifically kind of in developing a plan for each family and parent.
So, as an infant, we're wanting to make sure that we're getting nose breathing with the tongue up against the palate, which is helping keep the palate expanded. And then, as a 3, 4-year-old, we're now looking at making sure that, or we might be using a device to assist the expansion of the bones and the jaw muscles, correct?
Correct.
And that is also the age where they can sit still enough, hopefully, for the needed x-ray. So you're able to check to see how the tonsils are doing and how the airway is doing, right?
Correct.
Okay. And if those things are handled properly in those 2 phases, hopefully we are helping them live a life moving forward that does not have airway issues, does not have problems with getting oxygen, and therefore does not have the behavioral issues and the sleep issues and everything else that we see. Is there a phase after age 3 or 4? I'm not talking about the child that's never been seen before, but the child you were able to see as an infant, to look at the tongue tie, look at the breathing and the feeding, a child that you then saw at age 3 or 4 and worked through this therapy. Is there another phase after that, or is that when it ends?
That's a great question. So in traditional orthodontics, we talk about what we call a phase 1 and a phase 2. Okay, so phase 1 is that anywhere from 7 to maybe 9, 10 years of age. And that's the kids that might be in 1st or 2nd grade that we're seeing in braces. We also call that our interceptive phase. Okay, we need it, just like in football, you intercept a pass, we need to intercept a problem. I like to do more so what we call a phase 1A. And that phase 1A is the 3, 4, 5-year-old. I'm nearly all primary or baby teeth. Okay, and that's pure developmental orthodontics. I'm trying to change the trajectory of our growth. Okay. Then we get into that true phase 1 where we might be doing the orthodontic bracketing, meaning putting braces on the teeth at the same time. But then around that 12, 13, 14 is we're going to go look for that, what we call phase 2 or comprehensive orthodontic phase. And that's where we're bringing all things together. We're beautifying the smile, getting the bite in perfect position, because the goal at the very beginning may not be the perfect bite. It's to develop the ability to get better breathing capabilities. But many times the bite is off. And so that last part is going to be that second phase around the, where most of us had our braces around the maybe 7th, 8th, 9th grade years of life, is when we're going to do that last phase to finalize the aesthetic alignment and to fix the bite.
So if we approach straightening the teeth in multiple phases, I would imagine these smaller phases might make having braces at that final phase shorter and easier. Is that correct?
That's absolutely correct.
Okay, so because some children have braces on for what seems like 3 or 4 years, and it's a struggle, and they're cutting their teeth, and they're having to deal with the food, and they're not brushing properly, and they're trying to play sports, and they're embarrassed how it looks, and it's just very difficult for them to deal with. But what you're describing is, instead of putting this major braces treatment on the end, you're treating the patient early in life, the child, so that they can breathe well and develop their arch. And by the time they would normally have the major braces, so many things have been corrected that those major braces become minor braces to get the last aesthetic and the last bite things done. Is that correct?
That is correct.
Okay, so I think then if we could, that is ideal in bringing my child so that we can have them properly evaluated and treated. But sometimes you don't see kids until they've already developed the problems. They're 7.
Yeah.
They're 8. They're wetting the bed. So when you see a child at that age where, mom didn't know until now that there was an issue, how would you go about treating a child like that?
Yeah, I think it depends on what every dental student hated was when they're attending saying it all depends. It depends on every child. we're still going to use that same protocol with the breathe method. Okay, we're still going to look at the same things. We're going to look at tonsils and adenoids. We're going to look at the need for myofunctional therapy, need for expansion. But what may change in that instance, and we'll also look for a tongue tie, but what may change with the expansion is the type of expansion. So there is a tooth-borne expander, but the problem is what we're finding is teeth aren't great anchors. So we have to anchor to something. But again, when we put braces on teeth, the teeth move. And what we're finding is a lot of times we're going to get more tooth movement the older we get and less bony movement. So a young child, very adaptable, malleable bone, is going to get very good, we call it skeletal movement. The skeleton's going to change, minimal tooth movement. The older we get, that's what the judge is going to be, is how much bony movement do I need? And if I need more bony movement, then we're going to look to do something, what's called a MARPE. Great orthodontist in the Arkansas area, world-renowned, the Rogley family, has done some incredible data that says they feel like a MARPE should be started as young as between the 7 to 9 years of age. And that goes against a lot of what maybe the traditional orthodontic industry believes. It's believed that, oh no, this is only for adults. And so once I went to that course, I had a few patients come in and they needed full mouth rehab. What that means is I had to put this child to sleep because every tooth had a cavity on it.
Yeah.
By the end of it, I didn't have any really teeth left. I had a few permanent teeth in the front that were in, but no baby teeth left in just the permanent molars. But we had a severe breathing problem.
Yeah.
So I can't do traditional expansion in that manner. So that child at 7, we put a MARPE in. And this is what changed my world in my career is I took the before and after CBCT, and the change in the nasal passage width was absolutely night and day. I couldn't, even if I wanted to, create those changes with the tooth-borne expander. And that's when I realized we need to be brave enough to sometimes break the mold of what our traditional Western medicine says on how things should be done. And sometimes that comes with a little outside pressure of you're being cowboy, you're doing things inappropriately. But when you're having parents come back over and over again and saying, Dr. Workip, you changed our life. I have my daughter back. That's a very different experience than, hey, your daughter's teeth look straight.
Yeah.
But when they come back and say, Dr. Workup, I have my daughter back, that's a wonderful day to go to work.
Okay, so to dive into this, you've mentioned 2 ways to expand the arch to the proper shape. One is what you call tooth-borne, where on a very young child, their bone is so soft that if you put what's called an expander on the teeth, the bone will move and expand.
Yes.
But as that child gets closer to age 7, 8, 9, the bone's not so soft anymore. And if we put an expander on the teeth, instead of the bone moving, the teeth move. And so you mentioned something called a MARPE. Is that where we put like little pins into the jawbone? Is that correct?
Yeah, we call them implants, or we could call it an anchor, basically.
Yeah. So like I think back to my daughter, my oldest, 2 different occasions she broke her elbow, and she had to have these pins, placed in her elbow. These pins though are tiny compared to something like that, right? So these are tiny pins that are anchored into the jawbone, and when you use that on a 7, 8, or 9-year-old, you get an amazing amount, beautiful amount of expansion that you said even impacts the nasal passage to become healthy as well. Correct?
Correct.
Okay, so it sounds then like if I'm a parent and I've got a child who's 7 and we're dealing with these behavior issues, these sleeping issues, this bedwetting, it doesn't sound like I've missed my chance to address this. It sounds like I need to come in now, and there's options there that can still help my child get to where they need to be so I can have my child back, the healthy child that can breathe properly, that's behaving properly after they've had this restored.
Correct.
So then it sounds also like the breathe therapy, the protocol. Maybe you could describe this, but it seems to me like it starts as a newborn with tongue tie and with feeding and breathing. Then it goes into maybe a 3, 4-year-old with further potential expansion, all the way to the ages of braces, where it's kind of finished off in this very conservative but holistic way, so that they end up with a beautiful set of teeth, a great bite, but most importantly, they're healthy from an airway standpoint. Could you say that in your own words and telling kind of that path, that story?
Yeah. When we start young, we are able to develop the jaws in ways in which we wouldn't be able to the later in life it becomes, or it becomes more complex.
Mhm.
When we do that, we create better breathers and sleepers. We decrease the risks of ADHD, anxiety, depression, kids who focus in school better. We found that a study that came out said that the difference between 15 minutes of healthy sleep, okay, so deep or REM sleep, is a difference between an A and a B.
Wow.
That's fascinating, right? Like
Yeah.
our child who is putting in all the work to get where, to get those straight A's might be struggling because they just can't get healthy enough sleep.
Yeah.
And then we look into adulthood, right? And we say we've all had we've had a good night's sleep. But imagine if that was a consistent aspect. And so what I talk with parents consistently is the breathe method, when I look at their child, isn't just what do they look like today. I'm trying to guess, where do I think they might be going as a 30, 40, 50-year-old? And how do we intercede at 3, 4, 5, 11, 15, no matter when it is, to get as close to that ideal as we can, depending on wherever they're at.
So this entire time we've been speaking about children, right? Infants, 3-year-old, 9-year-old. What about as an adult? What if I have a hard time breathing? I know I wake up, or my wife tells me I snore, or I seem tired throughout the day, not focused like I should. I just don't feel like I ever get that full sleep. Can we fix this with me? Is this part of the breathe, or am I going to a different specialist? What is this for me?
Absolutely. What makes the breathe method wonderful is the team we have at our office. I work with some incredible clinicians. Dr. Katie Freeman, I would put her up with anybody in the world with her orthodontic skills.
Mm-hmm.
Dr. Bart Paxton, who is our more adult or family dentist. And when I am treating an adult, I need the three of us together, and we come down and we're going to sit for 30, 45 minutes in going over a case, because the nuances become a lot more intricate, where a growing child, their face is going to adapt with those growth. Your growth is set.
Yeah.
And so sometimes the unfortunate, and previously the only option would be a CPAP or surgery. And so we called an MMA surgery. They're going to break the maxilla, mandible, widen it, move it forward, put plates in. Why are you shut for 6 weeks? You're drinking through a straw for 6 weeks. In your career, who has time for that? Right?
Yeah.
I don't have time for that. I can't come to work.
Well, it sounds horrible. So you're saying the old way of treating this kind of smaller arch, this airway problem, was to break the jaws of the face and expand everything with screws and wire it all shut and have a patient like heal for 6 weeks and go through all of that.
Absolutely.
Or they're breathing with a machine for the rest of their life, CPAP, which I know people don't. They
Right.
might start, they just don't, because it's so uncomfortable.
Yeah.
So what are the options for an adult then that aren't this invasive surgery, or that isn't breathing with a machine for the rest of my life? What can I do to solve this problem?
Yeah. If we're looking at it again, there are appliances that someone could wear, right? There are snoring and sleep appliances, and those are Band-Aids, probably more than anything.
Mhm.
But we would consider a MARPI treatment also, where we can treat non-surgically. Again, the older you are as a male, it may require the bringing on an oral surgeon to, when we place the MARPI there, they might actually have to do a small surgery that helps kind of separate the fused growth plate, basically, in all intents and purposes.
Mm-hmm.
And then we can still get that proper expansion. But what happens for us as adults is when we expand, our teeth are set. We're going to create spaces. And again, just like we talked earlier in the patient who needed 4 teeth taken out, we take out teeth, we close and take out tongue space. And so what happens in the adult is we expand and we create spaces. But if I then close those spaces, I bring them back and I take away all of the effect that I just created in the expansion by taking away tongue space. And so we have to bring on the orthodontist in a way to close the spaces down in a sequential way. But then we need a general or family dentist to be able to do some, whether it be things like veneers or fillings, when we actually have to change the shape of the teeth by doing some what we call dental bonding. The difficulty with it, you almost have to relearn how to be a dentist. In that, if you would go to any dentist after let's say I expanded someone's mouth, I aligned, and then I sent that patient off to their dentist, they would probably pick up the phone and say, Dr. Workup, what are you doing? Why did you leave this patient's mouth like this? Well, if you don't have the understanding, and I close all the spaces, again, I just put them in a worse position. And so you need a team approach to be able to know start to finish on what is going to be needed, what are the costs going to be, and it requires a much larger investment for a parent. It's a much larger investment, and I don't want to run people off from it, but it's still an amazing, amazing option. And I think in the future, we're going to see this become very, very mainstream. And I think we're going to see a lot of people's lives change with it.
So if I'm to understand this correctly, if I've got this shrunken in arch, and I also might be missing some teeth from old braces where they pulled out my teeth, what we can do as an adult is use those small pins to place into the jawbone, and a surgeon can kind of release my old growth plates a little bit. And you're able to expand my arch to be that beautiful shape it's supposed to be, where I can breathe the way I'm supposed to be breathing. And that will leave some small gaps in between the teeth that the orthodontist and the general dentist can help close the right way, either through braces in a very sequenced or sequential way, or even I might be able to have a smile makeover with, maybe I wanted a smile makeover to begin with, and I can have a smile makeover where the gaps are closed, and now I've got a beautiful smile again. But the end result is I now have the proper size arch I was supposed to have, to where it's beautiful in function and beautiful in the way it looks. And that's surprising that, that's not a mainstream thing to do, but it's not a mainstream thing to do because now I'm speaking as a general dentist, we weren't taught about airway at all. So dentists were taught to just cut out what's broke and rebuild it. And if there's gaps, move everything in, completely ignoring that it is where we breathe. It's where our tongue is. It's where we get oxygen. And when that domino falls the wrong way and we don't get the oxygen we need, suddenly decades of unhealth, if I call it that, happen, right? I just wonder, in this today's epidemic of adult sleep apnea, I wonder how much of that started with the little butterfly flapping its wing of us not breathing well as a baby. It's very interesting to me. So I've got a different kind of question. Whether it's my infant that needs a tongue tie, or it's my 3-year-old, or even 7-year-old that needs the arch expanded, all of this is the right thing to do them. But sometimes things get expensive.
Yeah.
How as a parent can I afford this? What should I expect? Does insurance cover this? How does that work?
All dental insurance has an orthodontic portion to it. And that orthodontic portion can be put towards the check or treatment that we do at the office.
Okay, so it sounds like for an infant, dental or medical insurance may apply to help pay for some or all of this. And then as we go into expanding the arches, because that's done with a dental device, my dental benefits can also pay for that, specifically under like the braces portion of the dental benefits. That's correct.
That's correct.
And I know, as employers, most of us patients, we get our dental insurance through our job. But every couple of years, it seems like our job picks a new dental insurance. Have you seen it to where, we use some of our braces benefits for this in one year, and then our employer picked a new company the following year, and now we have a new fresh set of braces benefits again? Is that how that works?
Absolutely. That's one of the great things about it. And you're exactly right. I see that with the majority of our patients. They come in and they may use their once in a lifetime orthodontic benefit for our phase 1 treatment, but then the employer switches it and they get a whole new set again. And so what we're finding many times, it's covering a third, if not half of the cost per treatment case, per treatment phase that the patient needs.
I don't think patients know this. So the way braces are typically paid for in dental insurance is you get what you call this lifetime benefit, meaning, you get so much money to spend in your life on braces. But when your job picks a new company the next year, you get a whole new set of lifetime benefits with that. So even if you had braces in 1 year and you got a new insurance company, you could probably get continued care out of that second insurance company. Is that correct?
That's correct.
Okay, excellent. Okay, so imagine I'm a parent watching this and I'm saying, yes, my child snores or they gasp or they're having behavior issues or my newborn is having trouble latching on and they're definitely not breathing through their nose. I want you to look at my child. How does that work? What's the next step? What should I expect?
Yeah. So let's say for either of those, whether it be a tongue tie or we're talking the an airway assessment,
Mhm.
we're going to first come in, sit down. I want to go through your intake and I want to understand what made you want to pick up the phone to come in today.
Mhm.
And I want to understand what are the concerns that you have. Then we're going to do an assessment. We're going to do an oral assessment. We're going to check out the functional movements of the mouth, the tongue, the teeth. We're going to, for the airway assessment, we're going to take some pictures, x-rays, measurements, and then a three-dimensional x-ray. And then we spend about almost 20 to 30 minutes going over that together.
Mhm.
I want families to understand what they're investing their hard-earned finances in.
Mhm.
I want them to know what they're considering having us do to help their pride and joy. And I want them to feel comfortable with any treatment. And so that takes time. That takes the ability for me to help them have an understanding on their level of what I am noticing and why I feel like it's important that they consider the breathe method treatment.
I'm curious. This might be an unusual question, but you've got children. How many children do you have?
4.
4 children. Well, how old are they?
Yeah, girl and 3 boys. My oldest is 18, so I feel like an old man now. She's in college.
Yeah.
Then I've got 3 boys at home, 16, 13, and 10.
And when your 18-year-old was born, the breathe method didn't exist.
Correct.
Have you found yourself looking at your own children and wishing you had started this treatment, or have you treated any of them on this? What have you thought about when it comes to that?
Absolutely. Every time I look at my daughter smile, she's got the most beautiful smile. It will absolutely light up the room. But I know how wide her dental arch is. And I know that if I told her I was going to say, sweetheart, we're going to have you come in, I'm going to put a Marpy and redo your braces. And she would say, Dad, I love you, but there's no way. And so
Yeah.
I don't think, I think that quote unquote ship is sailed with her.
Mhm.
But every one of my kids, I've learned, I've made mistakes in my orthodontic treatment, but it helped me develop this. The great thing is I've got my youngest still at home, and he's my Linus from Charlie Brown thumbsucker, for the longest time. And he's going to be the one who will probably get the most benefit of the full breathe method treatment. But absolutely, I've had to have some of those regrets as a parent that I wish I would have had this understanding at the time that my kids were younger, because I think we could have changed a lot of the things that created a lot of anxiety for my wife and I.
Yeah.
That made us worry that, as teachers were saying, your child, is flunking out of the 3rd grade, and we thought we're failing as a parents, because we didn't know what was going on. But then as we began to have that understanding, I think even for myself as a parent, I just would have been able to relax a little bit more.
I'd like to describe my children to you, and I want you to tell me, are there some red flags where breathing might be an issue? I've got a 7-year-old who is just now starting to not wet the bed, and she doesn't fall asleep well. And she has almost night terrors some nights in the middle of the night, just waking up a lot. And she's about a year behind already at age 7 in her schooling. And at home, she's very difficult, a challenging child because she can get angry or she cannot listen. Does that sound like someone that needs to be looked at?
100%. I mean, you really just checked off probably about 5 or 6 really glaring red flags
Yeah.
of things that I see that I'm instantly seeing a child who is in this constant fight all day long, that is trying to be the good girl, the good child, and doing everything she can, but is fighting against a system that is set up for failure for her.
Yeah.
And creating the right plan, and the breathe method is part of that. And then, as we look at other things of, dietary, screen times, all those things, as we look into that, I think you would absolutely see a difference with your daughter for sure.
And it makes me, as I'm sitting here, it makes me wonder, what is life like for her in 10 years, continuing on this path versus a new path, a healthier path. My second child sleeps well. He's always well behaved at school, makes great grades. You know, he talks back every now and then. I don't see any significant behavior problems, never wet the bed, was always ahead in school, has not been told there's any sort of behavior issues. So I would imagine there's no red flags there. Uh, of course, physically you can't see him.
Yeah.
Okay? My third child is incredibly intelligent, but always seems to be in trouble at school. He doesn't fall asleep very well at all. It takes him hours to fall asleep. He wakes up tired. He's incredibly forgetful. I think he's got, ADHD, but he definitely seems to have a challenge with focus. He forgets what he's told to do. He never finishes what he's told to do all the way. And sometimes that looks like he's misbehaving. Sometimes my wife is just at the end of her rope with this. Are there some signs there that he could have an issue with breathing?
100%. In a lot of the things that you're bringing up, I think sometimes the difficulty becomes what's normal childhood behavior and what are red flags. And those lines they mesh together, right? But there's definite signs. I want to go back to something you said, though, about your second child. I think your second child is the most easily missed. And those children, most of the times, it's not found out until it's your and I's age. They become very successful. And a lot of times, we call it the fit female syndrome. It's the, 30, 40-year-old woman who's incredibly fit, who's high achieving, who is very successful in her career, but is just pushing and pushing and it just always feeling like they're behind. And what happens is eventually as an adult, our body is incredible in its ability to adapt. But there will become a time where the body just says, I can't anymore. And that's as an adult when we start to see chinks and cracks in the armor where we can push through it for so long, but then we start having maybe heart issues. Maybe our blood pressure's going up. Maybe we start having some insulin resistance that's happening a little more frequently. Maybe we're finding, wait a minute, I'm getting 8 hours, but I'm just not very restful. And so your second child is one, he shows no signs because he might be the most, just strong-willed in a good way, who has the ability to push and has a discipline and focus that he gets from his dad and his mother and just two incredibly wonderful, developed people who have helped teach him that he has everything inside, but he might be still fighting his body. We just don't know it.
Yeah.
And so you're correct. It's so easy to look at, the first and third child that you gave and to kind of forget the middle child. And sometimes I think that middle child is the one that's kind of silently screaming out saying, hey, don't forget about me. And so what I always tell families is this, it's just worth getting an evaluation.
Yeah.
Because then sometimes we don't need to do anything. Sometimes it's very simple. It's very simple treatment. Sometimes it's just changing a sleep routine.
Yeah.
Right. But every single one of those, but the one who seems like should be nothing to me still has a red flag to it.
So it sounds like every child, just like with other aspects of medicine, every child should be evaluated.
Yeah.
And I, as a parent, will sleep so much better at night if I know that every one of my children was evaluated. And the earlier we catch this, the easier it is and the more significant it is for these children to go through therapy, right? Well, as we wrap this up, are there any last things that you would like to say that we haven't had a chance to review or discuss?
I think the thing that I would love every family to know is that we're finding answers. And I think what we have today versus what we'll have even in 5 years is going to be vastly more advanced every single day. And it takes being brave, being willing to step outside the norm. And as we do that, I think we're going to create a much healthier generation of kids in future adults and future leaders of the country. And that makes me really excited.
Well, you're one major reason why that's happening. You are the one training the dentist. You're the one that's developed the airway therapy. And you are one of the pioneers in bringing it to our country. And so I want to thank you for that. Dentists are going to you, Dr. Justin Workup, to learn your method so that they can go back to their practices and really change the lives of these children. And that is significant. Most of us never do anything that's significant in our careers, and that's something you're doing. And that is an amazing thing you're doing for us. So thank you.
Thank you.
All right. Well, I want to appreciate you guys watching this. Again, my name is Scott Luna, and this was just a wonderful moment for me to interview Dr. Justin Workup, the founder and pioneer of the Breathe Airway Method. I've realized now I definitely need to bring my children in to be evaluated, and I hope that this has brought a lot of light to this topic in dentistry and topic in medicine. And of course, if you would like your children evaluated, please seek out Dr. Workup, the pioneer of this. Thank you so much.